Hi, my name is Jith Nair. I am a cardiologist at Baylor College of Medicine. And the topic today for this asynchronous session is management of end-stage heart disease. Um, so on the left there is my background, disclosures at the bottom. And I am a cardiologist with a specialty in advanced heart failure, cardiac transplantation, mechanical circulatory support, and pulmonary hypertension. So the session objectives today are to describe the basic principles in the management of end-stage heart disease. The session outline will include heart failure epidemiology, definitions, treatment overview, identification of end-stage heart disease, and the treatment of end-stage heart disease. We're going to start with a case presentation. This is patient RH. He's a 68-year-old male with a history of heart failure. A left ventricular ejection fraction is 20%. He's got coronary artery disease with prior bypass surgery and a cardiac resynchronization therapy with defibrillator. When a patient comes to your office and reports that he can no longer walk to his mailbox, he's on medical therapy for heart failure and his bypass grafts are patent by recent angiography. So the question is, does this patient have end-stage heart disease and is he a candidate for cardiac transplantation? So why is heart failure relevant? This talks about, we'll get into the epidemiology of heart failure. So heart failure is ubiquitous in the adult population and impacts all specialties. Approximately 64 million people are affected by heart failure worldwide. 1 in 5 people over the age of 40 will develop heart failure in their lifetime. It's 20%. And at 6.5 million, it's a leading cause of hospitalizations, patients older than 65, and accounts for 33% of total Medicare costs. As far as prognosis, 32% of patients have died within 1 year of their diagnosis, and over 50% have died within 5 years. And at 10 years, only 10% are still alive. So this is a deadly disease. What is heart failure? So let's get into some definitions. So heart failure is a clinical syndrome. It's the inability of the heart to generate sufficient cardiac output to meet the metabolic demands of end organs, or to do so only with increased cardiac filling pressures. Definition: heart failure is a complex clinical syndrome with symptoms and signs that result from any structural functional impairment of ventricular filling or ejection of blood. So there's really no reference to ejection fraction or systolic function, and no reference to etiology. You can define heart failure by systolic and diastolic dysfunction. A lot of times we don't have such a dichotomous separation when we look at these patients clinically. Systolic dysfunction includes reduced ejection fraction, increased end diastolic volume, decrease in contractility secondary to ischemic or a non-ischemic cardiomyopathy. Diastolic dysfunction is where there is a preserved ejection fraction, normal end diastolic volume, but you have decreased compliance, increased end diastolic pressure, often due to coronary disease, hypertension, and/or obesity. The most recent guidelines published in 2022 um, had three different sort of stratifications for heart failure. One was heart failure with reduced ejection fraction, an LVEF, left ventricular ejection fraction less than 40%, heart failure with mildly reduced ejection fraction, 41 to 49%, and heart failure with preserved ejection fraction, EF greater than 50%. So for medical school purposes, recognize that reduced EF is less than 40% and preserved, for the most part, has been greater than 40%. So we look at heart failure with reduced ejection fraction or HFrEF. This is systolic failure. There's insufficient ejection or pump failure caused by various disorders that derange the contractile function of the left ventricle. From an epidemiological standpoint, you see more males than females. And we can see on the left with our pressure volume loops, see a decrement or systolic volumes as well as decreased contractility. And these patients may have greater end diastolic pressures. Below is heart failure with preserved ejection fraction, where there is diastolic failure. The left ventricle is stiff, cannot relax during diastole. There's inability to meet the metabolic demands during exercise, and there's elevations in diastolic and pulmonary pressures with exertion. This heart failure with preserved ejection fraction or HFpEF is now becoming sort of more and more prevalent because it's associated with multiple risk factors. obesity, hypertension, diabetes. These are all increasing in the population. And you see an equally sort of equal distribution between the sexes, males and females, for this condition. And this counts for about 50% of heart failure. We can also separate heart failure into left and right-sided heart failure. Left-sided heart failure, typically ischemic heart disease, hypertension, aortic and mitral valvular diseases, or you can have a primary myocardial disease, infiltrative, genetic, infection, autoimmune. And here the pathology demonstrates left ventricular and left atrial enlargement. On the right, you have right heart failure, and this most commonly occurs due to left heart failure. However, cor pulmonale defines isolated right heart failure due to pulmonary causes, typically interstitial lung disease or COPD. Other causes of isolated right heart failure can include left to right shunting, pulmonary arterial hypertension, chronic pulmonary embolisms, such as chronic thromboembolic pulmonary hypertension, or something called arrhythmogenic right ventricular dysplasia, ARVD. And here we see the pathology of isolated right ventricular dysfunction, RV dilation with right atrial enlargement. Systolic and diastolic function can occur with left and right heart failure. However, HFrEF and HFpEF refer to patients with left-sided heart failure. So when we're working these patients up, we look at our patient RH. We look at the echocardiogram. On his peristernal long axis, you see a severe left ventricular dilation and dysfunction. In the short axis, eccentric hypertrophy. These patients will have increased wall stress. And in the apical four-chamber view, you can see dilation of all four chambers there. So patient RH, which kind of heart failure does this patient have? You can look through the answers below. This patient has heart failure with reduced ejection fraction. How do we treat stable heart failure patients? So let's get into treatment overview for heart failure. So first of all, we want to evaluate these patients thoroughly. You want to get a general history, look for prior history of heart failure, known cardiac diseases, hypertension, diabetes, systemic illnesses affecting the heart. Do they have a history of HIV? Are there any rheumatologic, neuromuscular disorders, infiltrative diseases such as amyloid, recent viral illnesses? Are they in an area that's endemic to Chagas disease, pregnancy? You can also look at social history, environmental exposures, toxin exposures, substance abuse, including medical therapy that may have affected the heart, such as chemotherapy. And then family history, you want to look at 3 generations for sudden cardiac death, heart failure, and muscular dystrophies. When you're evaluating these patients, you want to get an assessment of their functional class. Typically, we use New York Heart Association classification. 1 is those patients that have no limitation on physical activity. 2 is those patients who have slight limitation on physical activity. And 3 is those patients who have marked limitation on physical activity. Finally, 4 are those patients unable to carry out physical activity without discomfort. You can see the 1-year mortality rate on the right there. And New York Heart Association should be assessed on each visit and documented. It can change based on degree of compensation or decompensation. On physical exam, you want to look at findings consistent with heart failure. There may be shared findings, both that you'll see in right and left heart failure, cool periphery, cyanosis, orthopnea, delayed capillary refill, tachycardia. On the right, you'll see left heart failure. These patients may have RALs in their lungs, respiratory wheezes, displaced cardiac apex, as well as left-sided murmurs. On the left, you can see right heart failure symptoms. These would be lower limb edema, sacral edema, hepatomegaly, increased jugular venous pressure, and tricuspid valve regurgitation. Pulmonary congestion and edema can be seen as well in left heart failure. Pulmonary congestion and edema produce heavy, wet lungs. You can see pulmonary changes with perivascular and interstitial edema, particularly intralobular septa. You can see progressive edematous widening of the alveolar septi and accumulation of edema and fluid in the alveolar spaces. And sometimes what you can see is hemosiderin-laden macrophages, sometimes known as heart failure cells. And these are signs of previous episodes of pulmonary edema. So you can see there, patient RH there, And you can see his defibrillator, his cardiac resynchronization therapy there. Right-sided heart failure is commonly due to left-sided heart failure, but you can also see it when you have isolated lung disease. These patients will have hepatomegaly, and sometimes if you look at their livers, you may see a cardiac cirrhosis that be associated with nutmeg liver, which is modeled on exam, on gross exam. You can have jugular venous distension as well as peripheral edema. Multimodality imaging is important for these patients through the use of transthoracic echo which is essential for diagnosis. CT scan can be a non-invasive assessment of coronary artery disease. Cardiac MRI is important to ascertain for fibrosis, edema, infiltration. And nuclear imaging can look for ejection fraction, the presence of coronary disease, as well as inflammation in cases where you suspect things such as cardiac sarcoidosis. When you evaluate these patients by echocardiography, you can see certain characteristic changes. You can look at systolic dysfunction. You want to look for IVC engorgement that can happen when you have right heart failure. And on the right there, you may see evidence of right ventricular pressure overload, where the ventricle at the bottom right there is being pushed over by the right side. And this gives you an idea that the patient may have pulmonary hypertension. Cardiac catheterization is typically performed for these patients. First of all, to look at coronary disease. Sometimes these patients may have normal coronaries as seen in A, and these patients may have true dilated cardiomyopathy. The patients in B may have areas where they have true coronary disease there. Or you can see sometimes patients that may have sort of isolated coronary disease without infarction, and these patients may have concomitant coronary disease with a cardiomyopathy. Left ventricular end diastolic pressure can provide valuable hemodynamic information as well. So once we do this assessment, how do we define heart failure? So we want to use our ACC AHA classification or stages of heart failure. Stage A is those patients at risk for heart failure. These are patients who have hypertension or coronary artery disease. B are those patients who have asymptomatic LV dysfunction. So these patients are going to be invariably New York Heart Association class 1. Stage C are those patients who have known structural heart disease who are symptomatic. They'll have shortness of breath, fatigue, reduced exercise tolerance. And stage D, these are patients that have end-stage heart failure. So in patients with stage B and C, you want to think about targeted therapy to reduce morbidity and mortality. And in stage D, these are patients who have marked symptoms at rest despite maximal medical therapy. And this defines end-stage or refractory heart failure. And these patients need to be considered for advanced therapy such as transplant as well as left ventricular assist devices. So all of our targeted therapy addresses adverse myocardial remodeling. And so if we look at sort of the compensatory changes that occur that eventually lead to deleterious cardiac remodeling, we can look at this diagram. Here you have a cardiac insult with cardiac dysfunction that ensues from that insult. You have hemodynamic decompensation with increased preload, increased afterload, and decreased cardiac output. All of that leads to heart failure symptoms. In addition to that, these hemodynamic decompensations leads to neurohormonal activation, increased renin-angiotensin, aldosterone system is activated, increased catecholamines, increased endothelium levels. All of this leads to renal vasoconstriction and fluid retention, which propagates the heart failure symptoms. And we're targeting these neurohormonal sort of activation to abrogate the progression of heart failure. So what are these targeted therapies? We'll refer to them as guideline-directed medical therapy or GDMT. And this is what we use for heart failure with reduced ejection fraction. Again, these therapies are for reduced ejection fraction. And the cornerstone of therapy include beta blockers, are in blue are ACE inhibitors, angiotensin receptor blockers, or angiotensin receptor neprilysin inhibitors. You don't mix those therapies in blue. You choose one over the other. for whatever reason that may be. You also want to add on mineralocorticoid receptor antagonists such as spironolactone or eplerenone. And then on the bottom right there, the newest addition to this group includes sodium glucose transporter 2 inhibitors or SGLT2 inhibitors. These are the four pillars of HFrEF therapy. So the drugs include our ACE inhibitors, ARBs, and ARNIs. You can see there the number of different medications that we have. Typically, if we can, we use ARNIs or angiotensin receptor neprilysin inhibitors. But there are times where the patients may not tolerate or afford these ARNIs, and we can use ACE inhibitors, which are, sort of been around since the late 80s, or ARBs. Beta blockers are specific, bisoprolol, carvedilol, or metoprolol succinate, just those three. And our mineralocorticoid receptor antagonists include spironolactone and eplerenone, and the SGLT2 inhibitors include dapagliflozin or empagliflozin. There are some additional therapies that may be used in specific circumstances in those patients who are Black, or those patients who are intolerant of ACE, ARBs, and ARNIs due to renal insufficiency. You can consider the use of hydralazine or isosorbide. And digoxin is infrequently used, and really the data is there only to improve symptoms, as well as those patients that may be intolerant to beta blockers. We want to think about defibrillators in these patients. It's primary prevention of sudden cardiac death, where they haven't had any arrhythmias. These are patients that have EFs less than 35%, New York Heart Association class 2 or 3 symptoms on chronic GDMT, and expected to live greater than 1 year. ICDs do not improve symptoms. They're there as an airbag for the heart. So if it crashes, it'll shock you when you go into VT or pace you out of it, which the latter is preferred. Cardiac resynchronization therapy, the goal there is to improve the EF, and typically the indications include EF less than 35%, New York Heart Association class 2 to 4 on GDMT, sinus rhythm, and left bundle, typically greater than QRS, greater than 150. The goal is atrial synchronous biventricular pacing. These devices typically will also have ICD capabilities. They're there to improve symptoms and lead to reverse remodeling, where the heart reshapes itself back to normal. So we can look at our patient RH. He was initially treated with carvedilol, losartan, spironolactone, and furosemide. He underwent the CRTD, which led to improvement in symptoms over 3 years. He was later prescribed empagliflozin, an SGLT2 inhibitor, but he could not afford the therapy. He had multiple hospitalizations for heart failure in the past year and could only take furosemide due to low blood pressure. On his last admission, he had an appropriate defibrillator discharge from ventricular tachycardia. So clearly he's getting worse and he can't tolerate the therapies that we have to help. And you can see him on the left there after his recent discharge. So how do we know someone has end-stage heart disease? So identification of end-stage heart failure or heart disease. So one of the things that we can use is this mnemonic called I need help. So if the patient requires inotropes, medications that augment function, but at the detriment of increasing oxygen demand, that is one of the clues. You can also look at New York Heart Association class, end-stage organ dysfunction, ejection fraction going lower, defibrillator shocks, hospitalizations, edema or escalating diuretic agents, low blood pressure, or you're not able to use those medications anymore that you previously used, these GDMT prognostic medications. So this is a mnemonic that has been used to identify these patients. What are methods to assess and risk stratify our patients? If we look, include all of the above. You can use risk scores, cardiopulmonary exercise testing, 6-minute walk testing, right heart catheterizations to further risk stratify these patients. So 6-minute walks and exercise testing, as well as cardiopulmonary exercise tests, these give us functional capacity of patients with heart failure, and these are objective measurements. So this gives us real-time data on how these patients are doing, and we can also use these to evaluate therapeutic response. The Swan-Ganz catheter has been around since the 1970s. This is used to give us an idea of our filling pressures as well as our cardiac output. Recall cardiac output is stroke volume times heart rate. And our heart rate can be variable depending on our age, and our cardiac index is our cardiac output divided by our body surface area. A little busy here, but our heart failure evaluation through Swan-Ganz measurements can include the right heart catheterization above. We can get filling pressures that give us an idea of how compensated or decompensated these patients are, as well as the cardiac output and index, as well as measurements of our systemic vascular resistance and pulmonary vascular resistance. Below are our normal pressure and outputs that are seen in patients. You don't really need to memorize these, but they should be in a reference chart for you for any sort of examination. And we can look on the right there, our resistance calculation. So MAP over cardiac output times 80 is our systemic vascular resistance. On pulmonary vascular resistance is our mean PA minus our wedge, which is the transpulmonic gradient divided by our cardiac output. Normally it should be less than 2 Woods units. So we did this sort of right heart catheterization on patient RH. He's short of breath, he's got low blood pressure, and he has renal insufficiency. His creatinine is 1.57. A cardiac catheterization is performed, which demonstrated the values below. So he's got low blood pressure. His LV diastolic pressure is elevated to 27. His right atrial pressure is 25, very high. His wedge pressure is 25. He's got a cardiac index of 1.45 and his pulmonary vascular resistance is 5.7. This man is sick. So he's gone from stable heart failure. He's been coming into the hospital and having acute decompensated heart failure. Now he's in cardiogenic shock. He's got decreased perfusion. He's got congestion that's seen by the cath, right? He's got an elevated creatinine, so he's not getting blood to his kidneys, and his kidneys are deranged. And he's got low blood pressure. So you want to restore end organ function. So the management of this decompensated heart failure, acute decompensated heart failure, is to number one, identify our precipitants, do our assessment, functional class testing, physical examination, and think about therapy, diuretics, and afterload reduction. And you want to also look at what these precipitants are to avoid any sort of further decompensation, whether they be inadequate medication titration, medication interaction, uncontrolled hypertension, rhythm disorders such as atrial fibrillation, looking at their diets, infection, as well as concomitant pulmonary renal disease. When they're decompensated, you can do the simple mnemonic. You want to get them to have no congestion and have adequate perfusion. So they want to be warm and dry. And this represents normal cardiac index as well as normal wedge pressure. A lot of our patients come in and they may be warm and wet, where they just need some diuretics and their cardiac index, their perfusion is okay. But in a lot of scenarios, we get into patients where they have low perfusion. Their cardiac index is decreased. You'll do their physical exam. They're cold. That's decreased perfusion. And they may have a lot of fluid, so they may be cold and wet, or they may be cold and dry. So you can use this sort of simple sort of method to tailor therapy. With congestion, we use diuretics. And if they've got low perfusion, you can first think about vasodilators if they've got adequate blood pressure, nitroprusside or nitroglycerin frequently used. And then they've got low perfusion, low blood pressure. You can also think about inotropic agents, milrinone and dobutamine. Now, if they progress to cardiogenic shock, you want to assess for hemodynamic compromise and end organ hyperperfusion and identify precipitants such as myocardial infarctions, arrhythmias, infections. Their treatment is there to restore perfusion, improve end organ function. This is cardiogenic shock, where they've got deranged perfusion to their organs. And our goal is to recover function and consider for advanced heart failure therapies if you can't get them out of this, such as a transplant and LVAD. Below are there are different types of shock. So they can have some of these patients overlap. They can have distributive shock that you see in sepsis, hypovolemic shock. Typically, you don't see in heart failure will they have loss of plasma or blood volume. Cardiogenic shock is what these patients typically see, and obstructive shock can happen in the cases of pericardial effusions or pulmonary embolisms. So hemodynamic states can be very helpful. In cardiac sort of states, they'll have decreased cardiac output, increased systemic vascular resistance, increased wedge, and low venous oxygen extraction. So SVO2 is a measure of systemic perfusion. If we go back to our measurements of cardiac output, and these patients who have cardiogenic shock typically will have low SVO2s. So we have certain criteria that meet cardiogenic shock criteria, and this includes a systolic blood pressure less than 90. And you can have hyperperfusion, decreased mentation, cold extremities, low urine output, elevated lactate. So it's important on these patients to check lactate levels. And then when you do, there are hemodynamic assessments, low cardiac index, less than 2.2, high wedge pressures. There are other hemodynamic considerations that you can take that are a little bit more advanced. But these patients, if they meet that criteria, have cardiogenic shock. And when these do, you can think about inotropic and vasopressors. So adrenergic agents such as dopamine and dobutamine, vasopressors, sorry, norepinephrine, epinephrine. If they've got adequate blood pressure, you can think about milrinone, which is a phosphodiesterase 3 inhibitor. And then if you want to maintain their blood pressure, you can think about vasopressin, and sometimes these are used in combination. It's important to know the effects of these different medications. All of these therapies, for the most part, will increase your cardiac output and your heart rate. They can cause arrhythmias. Some of them more than others can actually improve your systemic vascular resistance, such as dopamine. Dobutamine and milrinone will decrease your systemic vascular resistance. Vasopressin, norepinephrine will increase it. And most of these will have negligible effects on pulmonary vascular resistance or decrease it in the case of milrinone. So inotropic are meant for short-term support, and they're sort of a whip for the heart because they increase myocardial oxygen demand. So what are the treatment options for patients with end-stage heart failure? So these include cardiac support devices. So if the patient has cardiogenic shock, you can think about temporary support devices. This includes an intra-aortic balloon pump, an Impella, which is an axial flow device, and that's the only one in the market, so hence we use its trade name. Or this tandem heart, which extracts blood from the left atrium via transeptal puncture and takes blood out and delivers it back to the descending aorta. So this unloads the left ventricle and provides a left atrium, sorry, and provides hemodynamic support. In cases of biventricular failure, you can do extracorporeal membranous oxygenation, where you remove blood from the right atrium or the inferior vena cava, deliver it to the aorta, and this provides full cardiac and pulmonary support. Long-term support includes LVADs and cardiac transplantations. LVADs are left ventricular assist devices. These have been around for several decades now, and on the left, you can see the current centrifugal flow left ventricular assist device system. This is the HeartMate 3. And this has been shown to have improvements in survival for those patients who have medically refractory heart failure. And we're looking at survival rates of 2 years of around 85 to 90% in these patients, whereas with patients who are end stage, we're looking at survival rates of 8% or below. Cardiac transplantation is used for end-stage heart failure to improve survival, and this is something, but obviously resource limited. Indications and contraindications for transplantations are very important. And this includes end-stage heart failure and contraindications if they have active malignancy or they may have a systemic illness outside of heart failure that limits their survival. And then all of us have relative contraindications to undergoing a transplantation. So the LVADs are there sort of as a way to augment heart function, and the HeartMate 3 is the currently used device that we use. And something on the horizon that is very unique. We've had total official hearts now for several decades, since about 2004. But an innovation at the Texas Heart Institute in Baylor has been the development of this newer device called the Bivacor. And in the middle, there is a radiograph from one of our patients who actually underwent, he was the first human to undergo the Bivacor. And this is a total artificial heart that's undergoing current clinical study, but will hopefully be there as a complete replacement for transplant at some point. And finally, for those patients who are not eligible, we want to have early involvement of palliative care to allow for that transition for these patients and to initially to improve management in those patients who are not eligible for these advanced therapies to sort of shepherd them through their disease process, as well as consider hospice if they're ineligible for advanced cardiac therapies. So, patient RH eventually underwent successful transplantation. He asked, how long will a transplanted heart last? And the answer is 13 years. So this is what we're looking at for these patients. So in summary, we want to look at these patients by their AHA classification. We want to try to mitigate the heart failure, for those of you going into primary care, as well as cardiology. We want to treat the hypertension, the diabetes, the dyslipidemia. Stage B, you want to treat with therapies, including stage C. And then finally, identify those patients who have stage D early so we can offer advanced therapies to them early. All right, so I think heart failure is a common endpoint in patients with advanced heart disease. Treatment includes this GDMT, beta blockers, ACE, ARBs, ARNIs, MRAs, and SGLT2s. These therapies improve survival through targeting neurohormonal mechanisms. Additional heart failure therapies include ICDs and CRT. Acute decompensated heart failure treatment include diuretics and afterload reduction. Cardiac shock should be distinguished from other forms of shock. And the treatment includes diuretics, inotropes, pressors, and mechanical or circulatory support to restore end organ perfusion. And treatment for end-stage heart failure includes transplant, left ventricular assist devices, as well as palliative care. So I want to thank you and appreciate your time. And this concludes our session.